Welcome everyone. Thank you so much for joining us for today's webinar. I'm Patricia Elise here with AI4 and we're so excited to have you here today. Just a quick housekeeping item before we get started. Please drop your questions in the Q&A box as opposed to the chat. This makes it easier for us to get to all of your questions, so we want to make sure that we're able to answer those. Thank you so much, and I'd like to welcome our panelists to the virtual stage for the State of AI in Hospitals.
Great. Thank you very much for everybody for coming today. My name is Jeff Short. I'm the Transformation Officer, Chief of Staff, and I lead the faculty practice group at Montefiore HealthSystem. Irene, would you like to introduce yourself?
Sure. My name is Irene Louh. I'm Associate Chief Medical Officer for York-Presbyterian. I lead our AI department as well as our artificial intelligence divisions for the entire enterprise. And I'm also a practicing clinician in critical care.
Mike?
Yeah, really appreciate the invite to speak on the topic today. I've got a few roles. I'm the Chief Data and Analytics Officer at MountSinai HealthSystem here in New York as well. Originally built some data science and engineering teams, and then last year moved into IT, and now get to work on our enterprise data strategy and really putting all of our data assets and analytic data science capabilities together, both for the school, our research arm, as well as the hospital and operations.
Great. So our first question. Hospitals and artificial intelligence, perfect match or a breakup waiting to happen?
I was going to ask, wondering if we could just say, I feel like we're more in the flirting stage where we're just, as opposed to the two extremes. I don't know if what you guys think, Mike and Jeff. We're still really at that cusp and that forefront, or really starting to understand how we can best leverage AI in clinical care and healthcare. Whereas I think especially on some of the back end, the financial, the more corporate systems, I think we've made a lot of progress, and we're starting to really utilize AI as a tool in our armamentarium. I don't know what you guys think.
Yeah, just real quickly, I don't know if I would say it's a full yin and yang type experience, match made in heaven. I'd probably say it's more like walking and chewing gum. Maybe not everybody can do it, but it is pretty cool when you can. I know we've got more questions about the details of it, but it really is an amazing opportunity for healthcare, for hospitals to achieve our mission, and that is the future. But a lot of us are still in the walking and chewing gum phase, trying to figure out how to do both.
Yeah, no, I definitely agree. I mean, if you look at AI, and machine learning, when you have lots and lots of data and lots of complex problems, I think that describes healthcare pretty well. And we have so much data in healthcare, and we're just tapping just a little bit of it. And especially as I'm sure you've looked at, the devices now all communicate. So the Internet of Things is producing, millions and millions of data points every single day. And I read this interesting study that every 73 days, the amount of medical data that exists in the world doubles. And so that amount of data that we have available is just immense, and we've only really scratched the surface. And I'm sure that flirting comment really makes a lot of sense, because I've seen, and I'm sure you've seen stuff that's gone on in your own places, also around the country, where you see a lot of promise. There's a lot of promise in things that we can do with our artificial intelligence. And I've seen studies where people predict by like 2026, Accenture had a study that we'd be able to save $150 billion in healthcare through artificial intelligence, which everyone's like, oh, that's fantastic. But then yet in the last few days, IBM is putting IBM Watson on the market, which was like years ago came out. We're like, oh, this is great. AI is coming to healthcare. It's fantastic. And that's about to be sold. So I think, yeah, it's really trying to figure out what is this really going to be long term, because I think it's pretty unclear. When you look at what happened with Watson, I think a lot of it is, how do you apply this stuff, right? How do you make this work? I mean, because you guys have seen success and failures as well, right? I mean, is there any clear application that you think are fantastic, or it's really that AI and machine learning is well designed for?
So I'll jump in here. I think Watson is a great example of it's a capability, it's a tool, but if you don't know which business problems or clinical problems to focus on, it is just a tool at the end of the day. There is a ton of clinical research. Three of us belong to academic medical centers, and we have a big research arm. So a lot of the research is trying to help decision support at the bedside, optimized ordering, optimized just decision-making, clinical decision-making. And what we're seeing is a couple of problems with that. If it's not something that we can operationalize into our workflows, then we're just not seeing the traction. It could be a really great signal, but if it's not, if we have no way to really operationalize it, there's almost no point. And so it's almost like we're not looking for help with clinical decision support at the bedside. What we actually want to know is who are the patients that we need to worry about in the hospital at any given moment, and who are the ones that we don't. And so getting all this additional data, whether it's streaming, whether it's HL7, whether it's more static clinical data in the EHRs, and even bringing in socioeconomic SDH data, it's amazing for giving us signal. And if we can use it to help us understand in the next 15 minutes, 30 minutes, 4 hours, 24 hours, which are the patients we can worry about and not worry about, and so that we can use our valuable resources in a more specific, more efficient way, those are the ones that for sure we're seeing work. Those are the ones, they're by far the least sexy, but they are the ones that actually are making a bigger difference. They are freeing up resources to not waste their time walking through these mega hospitals, looking for patients to solve problems on. That's where the systems, that's where the models can really help us.
It's fantastic.
Yeah. I mean, I do think that's a really good point. I mean, I think that's probably one of our other questions. We feel like a lot of I think AI still sits in the sphere of that big separate shiny object. It's something different we add on, we have to apply. And I mean, especially even being I was on clinical service not too long ago, and I think you guys realize it too. It's the so what, right? Is it actionable? I think that's true for analytics and AI, right? If we don't have something that's actionable or meaningful that's coming out of our data, then it really isn't helpful or beneficial for healthcare. And so I agree, Mike, I think where we have seen the most success are in the least sexy areas of healthcare. It's a lot of the back office. Where we see a lot of promise, I think, is sometimes in some of those front-facing areas. But if it's not operationalizable, if it's not really ingrained into the normal workday or the work stream, it's not additive, then we can't impact as effectively. We can't really. It's really difficult to change processes and change culture, or even and change improve care unless it is really right there. And I think that's always that. I think that's true also for research. I think that research translation, or AI thinking about it more as a research innovative piece, that transition from pilot to operations is key. And I think that's that area of transformation I hope we'll see with AI in the next 4 to 5 years. But we haven't, I think, quite made it yet.
Are people more open, you think, though, to like obviously it's getting more and more press as time has gone on, but this is not really, we've been talking about AI for a long time, right? So do you think, and the three of us focus on it, so, but do you think other people that don't spend a lot of their time thinking about it, do you think they've changed their perception of it as far as the perfect match or not for healthcare?
I mean, I talk about this at work as, we have a demand issue. First off, a lot of healthcare hospital leaders forever have always have had a hard time just getting the descriptive data about, use the example, like how many belly buttons were in the beds last night. That used to take an army of people pulling data from different reg systems and teletracking and the EHR when you had it, and bringing all that data together to give it to a hospital president or a system executive. So, when you go to them and say, hey, we don't want to talk about how many people were in the bed last night. We want to tell you how many people are going to be in the bed tomorrow or next week or next month, so you can make changes in how you, how you schedule, how you order, how you start transferring patients around to create capacity. We want to start telling you about the things that have uncertainty. As a leader, I think they're asking themselves, like, wait a second, it took us 10 years to build these reports that I'm now making my decisions on. And that just told me about what happened yesterday. How the heck can you tell me about the future if it was this hard? And so I think there's a learning curve. I think there's a credibility piece to this that we still haven't earned yet as data scientists, as a data science community, trying to help hospitals. Again, like I was saying before, I think there are some clinical decision support opportunities that are really straightforward, where we can augment decision-making for a clinician. That's great, but I think if we want to really make a difference, the leaders of the organization, people who are accountable for the P&L of the hospitals, they need to buy in. They need to actually be trained and educated on what does it mean to ask for a data science project, and how do they be good customers? How do they have the patience to let us take the time to build something that actually is so meaningful that we can create optimization, create automation, and things like that, really help move the needle. I don't think we're there yet. I think they know we're still learning. We're still kind of, I don't know, we said we were in the flirting phase. We're still figuring this out. And so understandably, they're not ready to bet the farm on this. But I know they're pulling for us. I know they believe in it, and we just have to prove that it can work.
That's great. Irene, anything to add?
No, I mean, I'd have to agree with you on that. I think the other concept is true. Like, I think there is this general concept. We believe in data science, and I think I think sometimes we also flip through. We balance the daily operational challenges and the historical challenges with multiple EMRs, multiple systems. I mean, I know everyone's talking about teletracking, EHRs, our access systems, our telephonic systems. And so it's really hard for people to sometimes for leadership to wrap their head around the fact that we can actually think ahead and not just look at things retrospectively. I feel like there's that concept, and then there's also I think we also flip-flop with every project needs a data scientist, and every project needs something related to AI. And I think we need to, and I think that's the balance. And I think what we're working on, and I would imagine it's also a learning experience in other healthcare organizations, is really providing that data literacy and that analytic literacy of what it means to utilize data. What does it mean to utilize analytics? What does it mean to do machine learning and use data science and, implement some of these tools and these practices?
Yeah, so it sounds like if we go back to the relationship analogy, it's probably, we classify this as complicated, right? It's not totally there yet, but we'll show a lot of promise. Why don't we move on to the next question? What opportunities does AI afford hospitals? And please give examples. Mike, do you want to start?
Yeah. I mean, I'll give a few examples. Specifically within the hospital, predicting events, predicting falls, predicting sepsis, predicting malnutrition, delirium. My peers have been building things around this, helping us plan for discharge, helping us plan where they should go post-discharge, what's the optimal place. I think these are the areas that we've been focusing on. We have workflows that already existed with descriptive heuristic type reports and rules. And now we're just augmenting that with more high-powered machine learning. And that's, so it's easier to just improve a model that already exists versus trying to convince people to use a model from scratch. So I feel like that's where we've started and we've found the most traction. We've got one group that's focusing very much on what's happening in the hospital. We have a population health group that's focusing on what's happening not in the hospital. When do we need to do more outreach? That's really trying to bring more socioeconomic determinants in. But it's usually about, and I know I said it before, it's predicting events, especially adverse events, before they happen, so that we can plan for them and we can intervene. And then we try to measure the accuracy of the model by, how many adverse events end up happening, how many admits end up happening, how many readmits happen because we didn't discharge the patient to the right setting, or discharge them too soon or too late. That's how we know that these are working, because the goal of what we're doing in most cases is trying to eliminate adverse events.
That's great. That's great. No, just to piggyback on that, we're all from large systems where we've moved to large EMR platforms. We're moving some of our system hospitals over the next year onto Epic. And once they're there, we can take the things that we've done at our mothership main hospitals and just roll them out. It just takes advantage of that scale that systems like ours have, and can take the best thinking and we could take it from across the whole system.
I think that's really important, Jeff, as I empathize, as we're smack dab in the middle of our Epic implementation for our enterprise. So we're about halfway through. And we also did it, it's COVID kind of interjected its way into that space, as it did, I think, for you guys also. I do like the idea and the promise for AI, especially in the vulnerable patient population. I know Mike had mentioned, some of this predicting readmissions, predicting a lot of adverse events. And so I think the quality sphere is that other area, such as, it's not just it's adverse events, but, reducing our healthcare acquired infections. We have a lot of risk models, and you're right. These are great places that have good pathways. And can we take it up a notch? Can we add those at-risk populations and utilize AI and big data to really improve some of those models and methodologies to reduce, improve quality and some reduce HAIs, et cetera, or falls in some of those other areas? I think the other piece that, as Mike had mentioned, especially in a vulnerable patient population, what are those at-risk populations? And not only to come back to the hospital. I know the other area that's, for me, from a clinical standpoint, is the patients that really need to come back and have follow-up, and that transition from the inpatient and the outpatient setting and that connectivity. I feel that it seems that AI has really been focused, especially in the inpatient setting, with deterioration indices, with a lot of in clinical decision support, but bridging that inpatient outpatient gap, providing that continuum of care, and how we can better align that is, I think, another area of opportunity that we really haven't tapped yet.
Yeah, that's really fantastic. It really turns what we do into a real system of care, right? Versus just connected individuals working together around different patients, right? You really have a system behind it helping to drive and take advantage of a lot of the things that we want to do. One of the things that we've been looking at is the ability to extend a lot of the stuff that we're more impressed with that we've been able to do is around critical care. And as we expand Epic into our community hospitals, if you have monitored beds, you have the ability to really extend the critical care team out into those community hospitals, because they can monitor the patients as ventilators could be controlled remotely, be monitored remotely from a command center. You have all these new care models you really couldn't apply just a few years ago. And it's much better for the patient. They can stay in their own community. They don't have to be brought down. And then we can, with predictive algorithms, we can say, okay, this person's in trouble. We need to either do something differently there or bring them to somewhere where we could treat them at a higher level of care. So it's really exciting what AI enables us. It's just how, to your point before, Mike, how do you convince them that we're going to try this? We want to run an experiment where we're going to keep critical patients out in a community hospital longer than we typically would, and we're going to see how it goes, because it's like you said, until about a year ago, it's impossible to get reports on a daily basis, right?
Yeah, we see leadership education as a key enablement to this. We are working with our talent development learning teams to actually develop a data-driven decision-making academy with programs that would include sort of hands-on experience doing a data science project. I'm not going to turn my COO into a data scientist in a week or anything like that, but if we can give them a taste of one, what really bad data quality actually looks like, and then two, how do we take data and turn it into actual informatics, actually give them a taste of that experience, some of the tools, and actually help answer questions, then I think they'll have a different level of appreciation and empathy for what you can do with this. And then hopefully they'll start mixing that with their ownership of these P&Ls. Be like, okay, I want that kind of capability. If I knew the answer to this question, how could I run my business differently? That's the aha moment we're trying to create. We have it happening inconsistently, which means we have ways to go, but at least we think we can get there. We just have to work on our education, engagement, and tapping the executive leadership to make sure this is a core competency that they demand from their leads, and it just trickles down from there.
Irene, you have anything to add?
I mean, it's interesting. I concur. I feel like in that same theme, I think 5 years ago, even a year ago, data was really that afterthought, right? It's not that core competency. It's just what is there and the reports there, and understanding a little bit of the bones and a little bit of what's underneath, and how it's, captured, created, and delivered is really powerful. And I've had some of those aha moments with some of our peers and our executive leadership. And so also thinking through how you leverage some of those key collaborators and kind of your key champions to kind of in some of those areas that are really important, such as operations, such as clinical care, and focusing on what's meaningful, right? I think that's the other piece. What's meaningful to those on the ground? What's meaningful to the people who are in this day in, day out? How can we improve care? And then also, I think one of the things Mike touched on is how do you also improve kind of the quality of care for our employees, right? And how do we make our work easier, right? And enable us to do the job. And I think some of the other pieces are getting back to our patients, right? And so I think that's one of those areas of how we can integrate with data, and patient care also really speaks to leadership.
Yeah, and you brought up a great point. We talked a lot about some of the heavier, meaty issues that we address in healthcare, but it's also really useful for some of the more transactional or administrative-based functions, right? That it gives us incredible tools that are used on all sorts of other industries, like with chatbots, with automated transactions, with just taking something where someone had to interact with someone in a 9 to 5, and you can make it now a 24-hour asynchronous interaction. It has just a potential as a business. So I think this is a good opening to our next section, our next question. What challenges do you face when seeking AI-driven solutions across your organizations? Please use examples. Irene, do you want to start this one?
Sure, I'll start this one. I think for us, one of the big challenges is standardization, and how we are a large health system. I think with hospitals that have come into the six-fold, over a course of several years. And so we uncover a lot of different practices and different processes. And one of the things that AI really truly requires, or automation, is a standard practice. And so our team, my innovation team, often laughs because they're like, we're really not an AI team. We are a change management team, because that's what we do. It's the core of our business, is really quality, it's quality data and understanding workflow, and how do we standardize it so we can then implement a tool. So I think that's probably the biggest misperception that people have. I think sometimes people think that you can just drop AI into a problem and the problem's solved, and recognizing that it really is an operational, huge operational change in some cases, and bringing everyone together for that. That being said, once you do it, it's great success. So
I think that's a fantastic point. And that, in the example for Watson, right, that's really, it's change management issue. No one really doubted the technology could provide some use, or that it could discover interesting things or insights into a patient. But the fact is, how do you actually get people to change the way they practice medicine? How do you work that into a use case that's meaningful, that a clinician knows what to do with that information at the point of care? Mike, anything to your reaction?
Yeah, I mean, I think the biggest challenge that we're facing is, the more complex the AI model is, especially as you move to deep learning and neural networks, the more black box it becomes. We have less and less ability to explain to the person who needs to now take this information and then go ahead and place an order, or decide what they're going to do for a patient or for a business. And we're asking them to do that, take this number and then go take an action. We would love to be able to give them all of the drivers of where that number came from, but the more complex the model, the less interpretability there is. And that's moving in the wrong direction. I know there are new techniques that are being developed to try and help build interpretability into existing models or future models. I think that'll be an important hurdle for us to get over as an industry. There's also, a real worry about bias in the models around equity. And so we're spending a good amount of time now trying to really measure whether or not these models have bias in them, have racial inequity in them, that we're just systematizing because of other things that happened upstream. And now we're just amplifying and speeding it up. So that's concerning. We're a much more conscious society, and this is our chance to play our part to help sort of break some of those systemic issues. And so I feel like these are opportunities. If we can figure out how to create more interpretability, more transparency into what's in the model, then I think people will be more willing to listen, believe, and then take action. If we can show that we're thoughtful in how we think about bias and equity, I think they'll be even more likely to accept it. The other piece, just to add here, we've tried to, in some cases, dumb down some of our models, not go with what is the most precise, to just try to be able to find more interpretability. And so we can, we'll give people a model, and then we'll segment the population within that model. So it's sort of a stratification / segmentation approach, because the segmentation is just totally understandable. We're going to segment the population this way and stratify within that. So again, it just gives us better credibility, and that's key at this early point in the journey.
Yeah, no, that's a great point, because one of the things, right, when you get the result, what do you do with it, right? You can get a better model to predict readmission, but what do you do with that information if it comes to you? One of the things we always try to do is, how do we work it back into Epic, right, into our EMR, into the clinical workflow, so that if this result comes back that predicts this event or this status, what is the clinician, what is the team supposed to do? What what workflow does then trigger? Because otherwise it just doesn't really provide a lot of value. And then because they don't know what to do with it, they'll somewhat ignore that and step away from it. We have a great question that relates to barriers, and it's around privacy and patient security for AI deployments. And obviously, healthcare information is extremely sensitive, and I know the industry takes it very, very seriously. There's also the regulators take it very, very seriously. So for us, it's almost question one, is how do we protect the patient's data? Are we using it appropriately? I don't know if Mike or Irene, you want to comment on that.
Yeah, I think that's, I'm happy to comment on it. I think we treat, an AI algorithm, I think this is one of the places that's fast evolving. There isn't a playbook for it per se. And so we've struggled in our info security teams and a lot of our data sharing teams and across our schools, since we're a tri-institutional organization, especially with our EMR. And so we treat the algorithm and the AI itself just like PHI and HIPAA. And so, and we utilize all the same standard protections and privacy that is required and then some. And so it's actually in somewhat been a challenge, not a challenge, but it's been informative because in terms of if we're working with other companies or working with other organizations, it's pretty rigorous to try to actually ensure the protections and the privacy. And I think the other challenge or the other piece that's is that black box, right? that we live in with AI. And so how do you communicate that, for example, to patients for your patients, right? From a research study, we're taking your data, we're mushing it up. We have no idea what's actually happening, and it's spitting something out. And so I think it's going to continue to be important at the forefront, and especially also the other pieces as things move to cloud, right? And as more is in cloud, more than as opposed to in our home databases and on-prem, I think data security and patient privacy is going to be at the forefront again.
Just to add, I mean, again, coming from a large research facility like all three of our organizations,
it's complicated.
We have a lot of experience reusing patient data for research and knowing how to do it in a robust way that protects patient privacy. In the industry, mistakes have happened, and the good thing is we hear about them, and then that really helps us up our game and lock down some of those holes, whether it's working with third parties, whether it's being overly confident or overly comfortable with what the cloud can provide. We're learning maybe on the backs of some of our other colleagues around the country who hopefully have made more mistakes than we did. But we already have a lot of good, robust process and experience. I think the challenge of AI obviously is it's a lot more data, it's moving faster. And so the amount of risk grows versus a small clinical trial with a couple thousand patients. Now you're talking about 3 million patients being used to train a model. So the risk goes up, but fortunately, I think we have good process. For us, we're trying to create de-identification at scale and tokenization at scale because we really love to enable research happening very quickly. We think we can do that through de-identification and a sort of sister organization back in Israel has been showing us how they're doing more synthetic patient development. And we think these two things are the future. Take your data sets, build synthetic patients, and then allow a lot of people to be able to work safely with no patient privacy issues at all, because they're not real people. They're synthetic people that were built off of real people. I don't know if that brings up other ethical questions, but we think that's the future, are these two approaches, because there's no way my team at our scale are going to solve all of the clinical and hospital decision support problems in the world. We would love to expand that to have a crowd, but we need to do it safely. And so we're trying to create different routes to de-identify at scale.
Yeah, that's consistent with a lot of the things that we're doing, where we're sharing data with other organizations. Is really figuring out how to do it with de-identified data. Again, it raises the confidence that we're not sharing things inappropriately, and I think it's the key to really get people to trust a lot of this stuff. I think sometimes, and I think it's appropriate that we almost take it. It's already a high level of precaution to protect patient data. But I think for some of these new technologies, it feels like we're almost doubling down to make sure that we don't have a misstep, because there's natural skepticism whether this is effective or the right use of time and resources. So I don't know if you agree with that, but it just always seems that we ask a lot of questions about data security, which is appropriate.
Yeah. I definitely would concur with that. I think the other place that I think where synthetic data is going to be could be very powerful is the recognition that it is much more difficult nowadays to de-identify data and have a truly de-identified data set. And so I think that's the other area we're definitely doubling down in terms of our security and privacy place. And so I think I am really excited to see the promise of synthetic data and seeing if that could actually solve some of the problems, recognizing, as you said, there are some other limitations and, ethical considerations for that. I don't know where it's going to go, but I think those are the other pieces playing into this field.
I think one area that's really going to open this up and make this more interesting and more complicated is as the interoperability rules come into play, and you'll start to have patients being able to request information and share information. It's at the press of a button. If all the major players, they'll start paying fines if they deny some of these, if things go through the way they're planned. And so then it's in the patient's hands, they may not know when they're giving away their data to somebody, just because they don't have much experience with it, where organizations that deal with it day in and day out do. Great. Why don't we move on to our next question? Are you using AI in any capacity to assist with COVID-19 efforts? If so, how?
So I'll jump in here first. Being in a New York health system, when we were at ground zero of ground zero back last March, April, there was an amazing sense of urgency to just try to create something known out of all this unknown. And so while the clinical side of treatments and protocols was just evolving so rapidly, I don't think we tried to tackle that per se with AI or with machine learning. What we wanted to be able to do was just, could we predict how many more beds we're going to need, how many beds we're going to need tomorrow, in 2 days, 4 days, when do we think the surge will hit its peak? And so in the month of March last year, there was a really concerted effort to try, three of our smartest people got together and really whiteboarded this out, came up with some different approaches, and then started working on it night and day to build a model. And once they found something that had signal and was predicting the peak of the surge around April 9th, April 10th, 11th, something like that, it was such a safety blanket for leadership, because the online models from UPenn and some of the McKinsey ones, some of the other ones that were publicly available were not well built and had a lot of really bad assumptions, and scared the crap out of our executive leadership when they saw what happened when we put our market cap, our market size in there. They're like, no, this is crazy. There's no way that could happen. And fortunately, we were able to design models that showed, with good accuracy, good prescription, what the capacity was going to be, what the needs were, and they were able to expand to that level with some margin of error in there. And then as it started to come down, there was just a real sense of relief that these models were working. So all these leaders who had never necessarily believed or gave much credibility to AI were all of a sudden sleeping better at night, knowing that this predictive model was running every day. By the summer, when the protocols started to really harden, I think we were able to use a lot of that new sort of solidified process as training data and build up models around ventilator usage and a couple other predictions, which have proven to be valuable, but I don't know if they were necessarily groundbreaking compared to the impact of being able to predict the surge.
That's a great point. I remember the early models, those first the first ones you mentioned that we didn't have a lot of data yet. I got physically sick when I saw, like, when you put the New York data in there and use stuff from Italy and China, it was like, we're gonna have it's gonna be really bad next week. But thankfully, as we got better at that modeling, we got much more confident in where we were.
Yeah.
Irene, I don't know if you have any, is that what your experience?
No, I mean, I think we were all doing similar models at the same time. The two other places that I think have been really important is prediction of recovery, and especially in planning purposes operationally for some of our recovery units. And this is on the clinical side, some of the, in planning in terms of the long tail in our patients and our patient populations. And I think that's really helped us plan for second and possible what our March is going to look like. The other place that we really leveraged technology was in our COVID hotlines, in leveraging some NLP and processing for patient calls in our call centers, because the volume of and algorithms in terms of some of the scheduling for our employees and from our patients, patient side in terms of questions and answered because of those volumes, to enable patients to at least get, based on algorithms, information on how to quarantine, how to be referred to the CDC, or refer to CDC website, refer to testing centers, et cetera. And so I think that was a very valuable implementation, and being able to get patients to the information that they need. I think the other place where I know a lot of people use that commonly was in chatbots and some of a lot of our online work with on our web facing and our portals. So again, you're right. It's more of I don't want to say the back office, it's the non-clinical side, but it's equally important. Just patients are really needing to get to that information and being able to deliver it in a timely fashion.
Yeah, we found the modeling has been absolutely fantastic and probably the biggest impact on the organization. And we too, even vaccines as well, using AI-driven chatbots, we got to get information out and using the algorithm for contacting patients that were probably eligible for vaccine. It's been an incredible tool to quickly make moves on that area. We have a center for, most of our work is at our Center for Health Data Innovations, and we have Dr. Parsa Haji, who's a researcher and leader in this group. A lot of our work has been around critical care, and they have a deep learning algorithm. And what it does is essentially it pulls in all the information from Epic on a regular basis and puts information back into Epic. And it had the ability to predict respiratory failure and death in the next 24 hours and 48 hours. When COVID started, we essentially turned that onto ARDS, right? So how do we predict essentially acute respiratory distress syndrome? And so that tool was we then created Clinician Dashboards that was really only given to our critical care team. So they had the ability to receive that information, because it was still new tools for them to figure out, okay, how are we going to manage the influx, the crazy wave of patients that we had coming in. But it was really neat how quickly we were able to move on that and many other things. COVID's been incredible, and the learning cycles, how quickly they change. And I'm hoping that what leadership saw and clinicians saw during that period will hopefully knock down some of the change management barriers that we've spoken about today. And hopefully that those learning cycles and that rate of change in healthcare will continue. want to move on to our next question. Where do you see hospitals headed over the next 5 years when it comes to AI technologies? Irene, do you want to kick us off?
Sure. I feel like it's one of the, I mean, I do feel it's something we've kind of discussed and themed, threaded through here. I really do feel that in the next 5 years, AI will be core and integrated into many areas of our clinical and operational work in healthcare, as opposed to this kind of where it sits, I think right now, is this shiny object, as we've said before. It kind of is this, it's a special project, but instead, you know, we will think about AI as a core tool for how we solve problems.
Great. Mike?
I mean, 5 years is like a couple of lifetimes in the AI innovation cycle.
Yeah.
I don't think we're going to have like a Star Trek tricoder in the next 5 years that you just wave a wand over patients and they get better. I do think, you know, clinical decision support is going to skyrocket in terms of augmented decision support through AI. You know, I don't know. I'm really curious if the payment system in the United States will evolve in a way that lets us really take advantage of a lot of this prescriptive type capabilities. You know, can we, if you had a command center and you had a team of nurses and they were able to look over the patients across several floors and maybe even several floors on several hospitals, could you actually start to see a material decrease in the headcount of expensive clinical resources? And then you start, you know, okay, now you've really started to bend the cost curve in terms of hospital expenses. You know, whether you can squeeze length of stay or shorten length of stay down, you know, I don't know how much AI will help us, or you would hope it would, especially on the outliers or adverse events we could have predicted and intervened. So, I mean, I'm very hopeful that it will help us bend the cost curve, but I do know there's a lot of political challenges, lobbying challenges that are going to slow down our ability to innovate the payment process, which is just unfortunate. I'm hoping tools like RPA and certainly remote patient monitoring, which you were talking about earlier, is going to give us more efficiencies and more information to make better decisions. For sure, that's got to help us from a business process standpoint, but there's a lot of confounders to it. So I don't think it'll just be more of the same. I think there'll be something very revolutionary, but we need a lot of stars to align to really allow us to deploy it at scale.
Yeah, I agree with both your points. I think it's going to be iterative, right? We're going to run into the regulatory barriers and things that we need to change, and then it's going to be a slow change. But I think before you know it, it's going to be in everything, just like microchips are now. They're just in absolutely everything, and you don't even think about it anymore. And we're gonna stumble along the way, but I think it's one thing. I think COVID-19 has obviously kicked off a lot of innovation in healthcare. When you combine AI and now patients' acceptance and clinicians' acceptance of telemedicine as a reasonable way of delivering care, I think it will still see. I think the rate of innovation will be much higher. So it's a very exciting time to work in this field. And I think it's a benefit for large health systems and more opportunity for large health systems than regional players or smaller players, just because of our scale. So we want to open up for questions. We have about 8 minutes left.
Awesome. Thank you so much to our panelists. We do have a couple of questions from the audience. The first question is, how do you think AI and NLP plays a role when it comes to patient engagement and value-based care initiatives within individual PCPs, health systems, as well as hospitals?
There's a lot to unpack in that question. I'll just throw out something really quick. You know, the AI, natural language processing, is a capability. It's going to need a channel. That channel will come from consumer digital type interactions with the patient. You've heard us talking about bots. I think it's actually even more fundamentally simple than that. It's, do we have an app that is engaging enough that patients even know where it is on their phone because they use it, and that app is actually giving them information that helps them live their life better, that they spend 1-2% of their time per year in a healthcare setting. 98-99% of their time is not spent in one of those settings, and our ability to steer them to stay healthy and well in that 98-99% of their time is going to give us the bandwidth to actually do something. So I think there already has been a ton of innovation, remote patient monitoring, wellness apps, alerting, all that stuff is just so ready to be used. And the last piece of it is engaged patients who actually feel accountable for their own health. We have not figured that out yet, to be honest, as a society. So we're hopefully going to make more strides there.
To piggyback on Mike's comment about NLP, having a quarter to 30% of your visits via video will create all these open opportunities for augmented reality and for natural language processing of that interaction with the patient, which opens up. You've got so much more that's going now through a channel that you can analyze. So it's going to be very interesting.
Yeah.
All right. Our next question is, will AI make regulatory compliance easier or more difficult?
That's a lot to unpack too in one final, in one very small statement. I think we talked a little bit about how it can make it more difficult, or there's a regulatory challenge, right? That we need to work through what this means. And so I think in the short term, it's going to be a challenge as we work through that. I think AI actually does have the potential to make some regulatory compliance much, much easier with decision support, with some of these other nudges and just being able to consume and again, apply an algorithm and identify risk for lack of compliance, et cetera. But it's going to be a balance depending on what area you're speaking about.
I think it depends on your perspective too, right? Because regulators will have these tools as well. So they'll be able to identify misuse or fraud or problems in using data as well. So it'll be interesting.
Anything to add, Mike?
Yeah, where you said regulatory compliance, ideally a lot of healthcare is spent doing documentation. And if AI and natural language generation and some of these other capabilities could actually make the generation of documentation more seamless, that will both create efficiencies and should improve our ability to meet regulatory needs. I think we're a couple of years away from having our homegrown AI models be something that we have to document, just like we document medical decisions in the EHR. I'm excited about how we'll do that. I have no idea how it'll work, but those are the future problems that we have to look forward to.
Thank you. All right, I think we have time for another question. This question is, enterprises have invested in data lakes, stores, data marts, et cetera. There have been mining tools, MLDL frameworks, and other means to understand the data. What about applying AI to the decision maker or business user in the form of conversational analytics?
So I think the point that Mike made before about some of the biggest benefit during COVID-19, I think is that ability to use these tools at a high level to really for management being able to predict what's just happened and what's going to happen over the next few days, weeks, months, and years, and then allow us a better plan. So so I think that's a huge opportunity.
Yeah, just real quick, we're already seeing the technology side of augmented BI start to come into play, where you can sort of type into a Google search screen box like a question about data, and it will give you an answer. It's still early, it's still a little rough, but that capability of people being able to expect the machine to understand their questions, whether they type it or eventually speak it, that's for sure the world that we're headed down, and that will be a lot about conversational analytics, where the model will not only start to interpret the question, but also interpret the the person asking the question, so that we can give a response back in a way that they'll be able to take action. There's a lot of behavioral economics that are going into that we're going to steal from other industries like advertising, marketing, and we're still a ways away from seeing it at scale.
Anything to add there, Irene?
Not really. I echo both. It's going to be a bit of time, but it'll be there. We'll get there.
Awesome. All right, I'll squeeze in one final question. Oh, sorry, was there?
Yeah, I think a lot of the asynchronous opportunities for interacting with clinicians is going to be key. So you can have an interaction first via text, and then it's going to go back and forth and start to zero in on what your problem is, who you need to see, and then it'll go to a clinician. It could really increase access.
Awesome. So we're out of time, unfortunately, but this has been an awesome panel, and I really appreciate you all sharing your insights with us, and I know our audience has enjoyed it as well. So I'd like to say thank you to Jeff for moderating, and thank you to everyone for joining us today with these awesome panelists and these great insights. So we'll look forward to seeing you at the next event, and thank you all for joining us. Have a great day.
Thank you.
Thank you.
Thank you.